All right, good evening, everybody. So sorry for the delay. We ran into some technical difficulties. I think 2020 has given us all enough of those for the next couple of years. My name is Regan Bowden. I am head of global surgery and research at the UCT Surgical Society. And together with the UCT Division of Global Surgery, we are really pleased to welcome you to the second talk of this webinar series. The title of today's presentations is The Burden of Surgical Disease in Africa. As most of you will know, we started the series last month where Prof Muswime and Dr. Jacobs ran us through an introduction, a crash course into global surgery, giving us a bit of a background on the history and then telling us why it's important for us now. Prof Muswime, your mic is just interfering a bit. So the goal of the series overall over the next few weeks is to instill an understanding, passion, and skills needed for everyone who attends to play valuable roles in increasing access to safe, timely, and affordable surgical care. Over the next weeks, we'll be dealing with controversies, systems thinking, surgical innovation, and almost everything in between. On my side, a big thank you to Prof Muswime and the Division of Global Surgery for all the efforts putting this whole thing together. It really has been a highlight of 2020. I'm going to hand over to her. She is the head of global surgery at UCT, and she will introduce both of our speakers for today. Thank you, Prof.
Thank you so much. Thank you very much, Regan, and also just welcoming everybody. I mean, these are a big highlight of this year, as Regan has just said, and it's really exciting to be part of this and to be part of this team and actually putting together this webinar series. And we just see it, not as something that is happening now, but we've got the recordings online, and this will really play a big part of us developing the global surgery curriculum. And so there's so much worthwhile information that is coming out of these sessions, and looking forward to the next 6 sessions. But as Regan has also just said that, last time we spoke about the what and the why and defined what global surgery is. We looked at it more from a public health perspective, why we needed global surgery, and spoke a bit about it from a global health perspective. But today we're looking at global surgery in the context of clinical outcomes and in the context of surgical outcomes. We're also going to speak about women's health and women's surgery, and also just the difference in outcomes between genders as well. So without wasting too much time, I would like to introduce our next 2 speakers. Professor Bruce Biccard, who's the second chair of perioperative medicine and anesthesia at Groote Schuur and UCT. He's also the PI from the African Surgical Outcome Study, and that's, a lot of us know about it because it's one of the groundbreaking studies in global surgery. And he's also director of the African Perioperative Research Group. And then I'd also like to introduce to you obstetrician and gynecologist, Dr. Tracey Adams, who's also a gynae oncologist and also part of the Global Surgery Steering Committee. So I'd like to hand over to Prof Bruce Biccard to give his first talk.
Thanks, Salome. Right. I hope you can all see that. Thanks very much, firstly, for the invitation to talk this evening. This is a really exciting series of webinars, so congratulations to everyone who's put it together. I've been asked to talk about the burden of surgical disease in Africa, and I think a lot of this work has been done by the African Perioperative Research Group, which is a very important group of clinician researchers across Africa. There's more than 1,000 clinician researchers across nearly 40 countries in Africa who are contributing to the work that APORG does. These are my disclosures. I've got no conflict of interest for this presentation today. I've been asked to talk really to address three issues. The one, the epidemiology of surgical disease in Africa, and how to address and manage this burden effectively, and how the surgical system is developing to manage this demand. The first question I can answer fairly easily. The second and third are really difficult. So the epidemiology of surgical disease in Africa. So the data which I'm going to present comes predominantly from these groups. So it comes from the European Surgical Outcome Study, which was a forerunner for the International Surgical Outcome Study and the African Surgical Outcome Study, and then other work from APORG. And then the other group from the NIHR Global Health Research Unit on Global Surgery. They're based in Birmingham. They were originally the Global Surge Group. They've done a lot of work. And so between all these groups, we've managed to do quite a lot of work by amalgamating data and using the data to try and explain what's going on. So what you'll see comes predominantly from these studies and groups. So to understand the epidemiology, I think there are really 6 questions. It's really, what does a global surgical case mix look like? And then we need to ask, what's the volume of surgery that's conducted in Africa? What does the African surgical case mix look like? Who provides the care in Africa? What are the implications for these findings for patient outcomes? And then finally, I think you have to consider the quality of surgical care provided. So the global surgical case mix, this is probably one of the best global surgery publications of 2020. This is driven by the Global Surgery Unit in Birmingham, and using data from USOS, ISOS, and ASOS, they modeled basically what surgery is going on globally. And then from that, they can look at what surgery has been lost through COVID. But it's actually in the supplementary data, which I recommend you all look at. It's very interesting perspective on what surgery probably looks like globally at the moment. And so globally, this is what we see. About 1 in 4 surgeries is orthopedics. About 1 in 8 is head and neck surgery and urology. 1 in 10 upper GIT and colorectal. And then it falls off to about 1 in 20 is plastic surgery, 1 in 25 breast, 1 in 50 cardiac, and then down to about 1 in 300 neurosurgery. So that's globally, that's what the normal surgical case mix looks like. If you look at Africa, when the Lancet Commission for Global Surgery was published in 2014, they estimated that 95% of the population in Africa don't have access to safe and affordable surgery. And that's nearly 1 billion people. And so to understand what that means, we need to understand both the volume and the case mix and the quality. So a lot of what I'm going to show you now has got to do with the HDI, Human Development Index. I think this is an extremely important concept which runs through this whole presentation of the impact of HDI on your ability to access surgery. So if we start off with the volume, the recommendation is that there should be about 5,000 procedures per 100,000 population. So if we look at, I've chosen a few countries in Africa and their HDI ranking and try to move about 10 up each time. So starting at DRC at 180 down to Seychelles at 62. And you look at the cases per 100,000 patients that have been modeled from that paper I told you about. About 100 cases per 100,000 in the DRC, down to South Africa, which is about 2,000 per 100,000. And then I've shown you the relative increase in volume of surgery that would be needed to provide 5,000 cases per 100,000. So DRC needing nearly 50 times as much surgery. And really, this is what it looks like. So most of the African countries aren't even touching 1,000 cases per 100,000. So it's pretty dire how little surgery is actually happening in Africa. So besides, you know, the surgery that's provided, there's hardly any surgery happening. And what's the surgical case mix? So again, if we start off by considering the HDI, so this is global at the moment. So most of the countries in Africa are in the 4th and 5th quintile of the HDI index. And so what I've taken is the first quintile, and we'll assume that is probably what would be desirable for surgery. So, and if we assume Africa looks similar to the 4th and 5th quintile, sorry, this is what we would need. So of elective surgery at the moment, in the lower quintiles, only about 40% of surgery is elective. And that really means that it's predominated by emergency surgery. And the reality is we probably need to increase elective surgery by about 170%. We look at obstetrics and gynecology, we see here that a large proportion of surgeries in low HDI countries is obstetrics. And actually, this is what skews it. Of the few surgeries that patients get, a large proportion of them are obstetric. And that means that most of the other surgeries actually are hardly happening. In ASOS, we saw 1/3 of all surgeries were obstetrics. If we look at cancers, so we got gynae, colorectal, head and neck, plastic, upper GIT, and urology. The proportion of surgeries in these specialties for cancers range between 100%, or what we would expect from a high-income country, to over 400% increase needed to meet the demand. So the majority are in the range of needing to increase cancers by about 2 to 3 times. If we look at benign pathologies in those groups, we see that the benign pathologies are predominating. So we're not really getting to treat the cancers in Africa. Proportionately, we're treating much more of the benign pathologies. We look at elective orthopedics, we probably need to double the volume of orthopedics we do, and other surgeries. So this is a mixed bag of things like vascular surgery, neurosurgery, cardiothoracics, probably need to double as well. So let's look what's happening in Africa. Again, so I've chosen those countries to reflect an increasing HDI ranking from the DRC at a low 180 to Botswana at 95. And what I've done is I've chosen the UK in the top row as an example of maybe an aspirational target. And the reason I chose the UK is because they actually run at very close to 5,000 cases per 100,000. So if we look at that and we look at the volume of surgery across these countries, we can see that we need to increase volume by 50 times in DRC and down to Botswana, which is probably running at the right volume. And if we look at cancer surgeries, about 660 surgeries per 100,000 are cancer in the UK, compared to 12 in DRC and about 300 in Botswana. And what we can really do is, from that, we can look at the proportional increase in cancer surgeries needed. So, I mean, Botswana probably needs maybe 2 to 3 times increase in cancer surgery. And then you go right down to the DRC when they need to increase it by in excess of 50-fold, which is really devastating. And in fact, we can do this for all these different surgeries or categories of surgery. So we can look at benign surgery, we can look at obstetric, and we can look at that mixed bag of other surgeries, the neurosurgery, cardiothoracics, vascular, etc. So for benign surgeries, again, Botswana, Namibia, South Africa maybe need to increase 2 to 3-fold. But most of the countries are needing, even though the proportionately, I showed you earlier, the proportionate component is probably acceptable, the volume is far from acceptable. They're going to have to increase the amount of benign surgeries in the region of 10 to 15 for most of the countries, and then down Ethiopia, DRC, Tanzania, up to 50-fold. Look at obstetrics. Again, obstetrics for Botswana, Namibia, South Africa is probably running at a volume number pretty much close to what one would hope for. But for the most of the other countries, it needs to increase about 2 to 3-fold, and down with DRC and Ethiopia, maybe 6 or 7-fold. The category which is most alarming is this other surgery. So these are often quite specialized surgeries. And you can see that in Ethiopia, it suggests that there's extremely little of these surgeries going on for the population. DRC, we've almost got no data there, so we can't even give any estimate of how much is needed. But most countries are needing a several-fold increase in these specialized surgeries. So I think if you ask me to summarize what surgery looks like in Africa, I would say this. Across Africa, we need to increase the volume about between 2 to 50-fold, depending on the HDI of the country. Elective surgeries across the board probably need to double at least. If you look at the proportion, that is the proportion of elective surgeries. If we look at the volume of obstetrics, 2 to 7-fold, cancer surgeries between 2 and 50-fold increase across the HDI rankings, same for benign surgeries, and other surgeries, they need to increase 25 to 1,000-fold. So, I mean, the volume is way off in Africa. The proportion of surgeries, certainly cancer surgeries, are going to need to increase about 2 to 3 times. The benign surgeries, the proportion is right, but the volume is low. And all other surgeries, we need to at least double their proportion and then a massive increase in volume. So what don't we know about the surgical case mix? Well, I mean, I'm giving you these broad brush strokes on cancer and benign surgeries and that, but I'm giving you no idea of what the cancer patients look like. So, you know, we're not talking about a patient with a stage 1 cancer, which you might see in a high-income country. We're just talking absolute numbers about cancer. And the reality is probably we're treating far less cancers. We need a huge proportional increase, and we're probably seeing cancers present at a much later stage. So that's not reflected in the numbers at all. So if the graphs on that look devastating, they actually look worse because of the late presentation of the patients. Who's providing the surgical care in Africa? So this is what it looked like in ASOS. If you look at anesthesia, about 1/3 of surgeries are provided by specialists, about 1/2 by physicians, and 1/5 are provided by non-physician providers. Surgery, about 1/2 by specialists and about 1/2 by physicians. The real problem, though, for surgical provision in Africa is that we know that you need about 20 to 40 specialists per 100,000. So that's an obstetrician, a surgical specialist, and an anesthetic specialist to provide safe surgical care. So there's an inflection point on the maternal survival. In Africa, in ASOS, there was less than 1 specialist per 100,000. So this is a massive problem for patient safety and outcomes. If we look at the data from the WFSA, and they've provided this heat map of anesthesia providers globally. And basically Africa, most of Africa runs at about 0 to 1 anesthesia provider per 100,000, and definitely the majority is less than 4. Now, these are any anesthesia providers, and there's been some modeling on how many physician anesthesia providers you need, not just any physician. And the inflection point is at about 4 physician anesthesia providers per 100,000. So we know that Africa, most of Africa runs at under 4 any anesthesia providers, but in reality you need 4 physician anesthesia providers at least. So, I mean, what are the implications for patient outcomes of these findings? So, I mean, a strong signal that came through from ASOS is that the patients who do actually get to theatre, so the few patients who get to theatre are of a low risk profile, but the majority of them are presenting for emergency surgery. So we've discussed that earlier, how little elective surgery is going on. And they develop post-op complications at a similar rate to high-income countries, but we know they're limited resources and there's failure to rescue. And failure to rescue is basically, if you have a complication, it's that complication going on and leading to death. And that's associated with increased mortality. So in ASOS, we saw that patients were twice as likely to die following surgery when compared to high-income countries. We saw that the complications were similar to high-income countries, and that mortality of twice the global average or high-income countries following complications is failure to rescue. Unfortunately, it is way worse with obstetrics. So what we saw in obstetrics is that in Africa, you have complication rates of about 2.5 of that of high-income countries, but a mortality rate that's 50 times that of high-income countries following cesarean section. So this is, again, failure to rescue, and I'm just going to try and put it into context for you. So if we look at all surgeries with a mortality rate twice the global average and similar complication rate, failure to rescue is mortality over complications. So it's about double the global average of failure to rescue with adult surgeries. Look at cesarean sections, mortality 50 times the global average, complications, let's say it runs at about 3 times that of high-income countries. Failure to rescue in obstetrics is about 17 times higher than high-income countries. This is devastating. I personally think it's got a lot to do with a hemorrhage and how quick hemorrhage is and how difficult it is to manage in a resource-limited environment. So the next question you have to ask is like, what is the quality of surgical care in Africa? So again, if you look, there's a relationship between maternal mortality ratio and HDI. So the HDI keeps coming through as a real important predictor of outcome. And we know that the majority of low HDI countries are in Africa. And when you look at quality of care, and this classic work from Margaret Crook, what you see is that there's a massive range of outcomes in countries across similar income groups, which starts to speak to an issue of quality. So it's not only the HDI alone, there's also the issue of quality. And looking at this work, which looked at maternal and neonatal mortality, when you look between low income and middle income countries, where there's 80 to 90% skilled birth attendance coverage, the maternal mortality can differ 12-fold in the groups, and fourfold for neonatal mortality. So quality of care is a really important issue. So can we get a handle or get a feel for what quality of care looks like in Africa? So I think the best we can do is looking at the surgical safety checklist, so as a surrogate of quality. And what you see is, as the HDI changes, the use or uptake of the surgical safety checklist increases. This has got very important implications, though, because what we find is that in countries with lower HDIs, the use of the surgical checklist is significantly lower as soon as you look towards more urgent urgent surgeries. And you don't see this in high HDI countries. So it's not a well-established part of care in lower HDI countries. And the second thing is that the use of surgical safety checklist is associated with less mortality and less post-op complications. So the fact that it's not being used as much has definitely got implications for outcome. And the reality is that the surgical safety checklist may reflect a broader issue of quality of care. So how do we address and manage the surgical burden effectively? So I think you need to think about this burden in the 3 critical failures model. And that's failure to provide timely access to surgical and anesthesia services. It's failure to deliver safe surgical and anesthesia care, and failure to rescue post-operatively. So I'm just going to give you some examples. So failure to provide timely access. So as we saw in ASOS, most surgery is emergent. And as I showed you with the epidemiology, there's hardly any surgery happening. The cesarean section rate should be at about 9 to 16 per 100 live births. In sub-Saharan Africa, we estimate it's running at about 5. And the result is that you end up with a higher proportion of emergency surgeries, and that leads to potentially avoidable mortality. So you've got excess emergencies, and you've got emergencies which are potentially coming into a low quality surgical service. So that's the first problem we have. If we look at failure to deliver safe surgical care, again, I'm just going to stay with cesarean sections to illustrate some of the points. But if you look at the mortality associated with cesarean sections and surgical and anesthesia care, one of the observations which has come up in a meta-analysis with Sarah Sobey's work is that there's an indication that if you have anesthesia provided by a physician, that potentially the outcomes might be slightly better than if you had anesthesia provided by a non-physician. Now, I'm not saying that this is necessarily the anesthesia provider who is at fault, but it may reflect broader systems issues. In other words, this is surgery which is happening in systems which are very resource limited. They don't have a lot of support. They don't have the necessary equipment. And the presence or the need for non-physician providers might reflect a bigger systems issue that one is dealing with. If we look at the predictors of mortality from cesarean section in Africa, we see the 2 drivers are bleeding, both pre and intra-op, and anesthetic complications. And if we look at the deaths, 1 in 4 deaths follow hemorrhage and 1 in 10 deaths follow anesthesia complications. So I think the big challenge for Africa, when you think of the first two parts of the critical failures model, is that how are we going to increase timely access to surgery? And we're going to help increase the quality of care that's provided during surgery. So that's the real challenge at the moment, is to get this part right. If we go on to look at the third part, failure to rescue post-op, and so we saw from ASOS that it was these limited resources in the post-op period that leads to failure to rescue when a patient develops complications and hence increased mortality. So in ASOS 2, what we've been working on is to try and increase post-operative surveillance. So we think if you've got limited resources and you can focus the attention on the patients at most at risk, maybe you'll decrease failure to rescue when patients develop complications and hence decrease mortality. So the primary objective in ASOS 2 is to determine whether increased post-op surveillance reduces mortality in high-risk adult surgical patients. The principle is focusing attention on patients at risk to decrease failure to rescue. This is a cluster randomized trial which has been running across Africa and is almost finished now. Basically, hospitals were randomized to standard care or an intervention arm where high-risk patients were identified through a risk calculator, and then these patients were flagged for increased surveillance. The plan was to randomize over 600 hospitals, and the trial was powered for mortality. Unfortunately, we're not going to get to 600 hospitals, but the trial is almost finished. I'm hoping you'll see it later this year. Increased surveillance. So what was offered was, we thought, if we can have something which is simple and generalizable, if we can show efficacy, then we know it could be used across Africa. And so the idea was you could offer any of these 5 interventions and offer as many as you can. So for high-risk patients, they go to a higher care ward, if there is one. Increase the frequency of nursing observations for those patients. Put the patients in view of the nurse's station. So not put them in a room or not put them behind the nurse's station so that people can see them. Have the family members sit with the patients and they can tell you, my dad looks bad, please have a look at him. And we got a high-risk bed sign that goes, a sign that goes above the bed. Finally, how is the surgical system developing to manage this demand? And I think these are the challenges to providing quality surgical care. So there's 6 core challenges which have been identified by Bate and colleagues. So these are structural challenges. Those are problems which relate to systems and resources. And I think we've discussed quite a lot of them in this webinar so far. Then the cultural challenges, which is about having a shared collective meaning, value, and significance. Educational challenges, physical and technological challenges, emotional challenges related to motivation, and political challenges. So what we did is we ran a Delphi across Africa with the clinician investigators from APOG, and they came up with 10 priorities. And really what I want to show you about the priorities is how they address so many of these challenges that Bates's model brings up. So these are the 10 priorities: a minimum data set for registry, training standards, an audit of what's available and an audit of training, minimum standards for post-op monitoring, communication and teamwork, quality improvement with surgical safety checklists, practice guidelines, outcomes after emergency surgery. So there's a real signal here that the clinician investigators across Africa really have a sense for where all these 6 barriers to providing quality care, and you can see how they've come up, especially things like the educational challenges and resource challenges. If we look at the cultural and emotional challenges, these are problems which could be perceived as related to shared collective meaning and motivation. And when you look at ASOS, what we see is that almost all the respondents in a survey about participating in ASOS, which you mustn't forget was totally unfunded and was run by clinicians working in extremely difficult situations, they pretty much all said they would participate again, they would do it again, and they would do it unfunded. There's clearly no problem, emotional problem here, or problem with motivation. And then just before the ASOS obstetric cohort was published with such terrible numbers, this video was released in Zimbabwe, and this was a pediatrician in Harare who was complaining about the frustrations of arriving to neonates who die because they're just arriving too late. She described what the data in the ASOS obstetrics cohort showed. And clearly highly emotional, but the interesting thing is how there is this collective belief, and so I don't believe there are cultural barriers either that Bates describes. So these are the comments that came through in our survey. By my participation, I want to help my continent. ASOS has served as an eye-opener to the possibilities and benefits of interdisciplinary and multinational research. I love collaborative research. Only Africans can tell the African story. I believe the biggest challenge we got is political. So until people accept that the third commonest association with death is surgery, we will always have a problem in making people understand the importance of this work. There are more deaths that follow surgery than HIV, TB, and malaria combined. And this is our biggest challenge to providing safe surgery in Africa. Thank you.
Thank you so much for that, Prof Biccard. I think you've given us all a lot to think about and in a really clear way. I mean, there's obviously so much more to say about this, but it's really distilled it for us. So thank you so much. I'm sure most of us have to go back once it's on YouTube and watch it a few times to make sure we understand it all. But you did such a great job. I really appreciate that.
Thanks, Rick.
Next up, we have Dr. Adams, who will be speaking too. Unfortunately, we couldn't get her computer to share her slides. So I'm going to be sharing my screen with Dr. Adams' slides. So if you hear her saying change slide, I'm really sorry about that. It's the best that we can do at this point. Can you all see my screen?
Thanks, Regan. What I'll just be saying is thank you. So I'm going to be speaking, or I've been asked to speak about the role of surgery in women, and I just want to say thank you for the organizers and for how well it's been organized. Thank you. Next. So just as a background, and as Bruce has mentioned, the landmark 2015 trial, which was done and published in the Lancet, thank you, highlighted a few things. It's essentially that due to surgery globally, 16.9 million lives have been lost. And as mentioned previously now, this surgical death surpasses the number of deaths due to HIV, TB, as well as malaria. And in Africa, a lot of the focus has been on infectious diseases, and we've been neglecting surgery for a while. Thank you. And what was also highlighted in that study is that 15% of all pregnancies result in complications that require emergency surgery. I'm going to speak a little bit about the cesarean section rate later, But in places such as Kenya and Uganda, the cesarean section rate is 0.1 to 1%, which is exceptionally low. And I'll chat a little bit about that. And once again, for cancer surgery, surgery is responsible for 65% of all cancer cure. And there's a lot of variation between South Africa and other parts of Africa. Thank you. Quickly, just to look at the maps, we know that access to surgeons as well as the distribution is skewed in Africa as compared to other continents. And then, really, thank you. What about Africa and surgery in women? So what the Lancet trial really did for me, it gave me a little bit of hope and some frustrations. The hope is that this was one of the few studies that looked at surgery in general and an opportunity for silos to be broken, and also an opportunity for our own narrative. One of the frustrations I find that women are often restricted to such as maternal health, and there's a bigger story to talk about with regards to women in surgery, not just maternal health, although maternal health is an important part and very significant. And as mentioned by Bruce, our biggest problem is politics. Obstetric outcomes reflect both political will and our health systems. And there's very little data in Africa, and we really need to publish and research more. Thank you. So when ASOS came out, as mentioned, this was quite an important study for us. Thank you. And if you look at ASOS through my eyes with the next slide, as mentioned, the majority of participants in this study were women, 66%, of which 33% were obstetric patients, 11.5%, and breast surgery was restricted to 2%. So I have so many more unanswered questions when it comes to women in surgery, motivated by ASOS. Thank you. So I'm going to speak a little bit about pregnancy and then about cancer and everything else. When a woman is pregnant, there are many expectations, there's excitement, and there's a view of elation in most pregnancies which are planned. But at the same time, you have many pregnancy complications, which can be early complications, as you see on the right, a picture of an ectopic pregnancy on ultrasound. We see a separate uterus and what it looks like at surgery, as well as complications after a cesarean section. Thank you. So what I can tell you about South Africa, there's a National Committee on Confidential Inquiries into South Africa, and they do triennial reports. Quite a lot of work done by Professor Sue Focus, who used to work in our department, as well as Jack Moodley. The latest Saving Mothers report looked at the triennial period between 2014 and 2016. Thank you. And the key findings was when they looked at the last 3 periods of 3 years, that there was actually a reduction in mortality among mothers in South Africa. If you take a look at that graph on the left, you'll see in 2008, 2009 was a very high maternal mortality rate. And this really was due to HIV. That was the time when we had our HIV denialism, as well as no antiretrovirals available, or very limited antiretrovirals available, due to a lot of work by the Treatment Action Campaign. We now have all our mothers being tested when they book an initiation of ARVs, if they are not on ARVs already, from the minute that they, and that has contributed significantly to the decline in maternal mortality rate in South Africa. There's been a 47% decrease in maternal mortality due to HIV-related deaths, and also a reduction in the potentially preventable deaths in South Africa. However, we are not yet there, but we are getting there. Thank you. So I'm specifically only going to look at bleeding. I mean, there's a lot of things that was discussed in the last Saving Mothers report, but I'm specifically going to speak about the surgical ones and refer to a section called bleeding due to or after cesarean section. And if you take a look in the period prior to the last report, we were actually a little bit worried because we saw a significant increase into maternal deaths due to bleeding at cesarean section. And obviously this could be attributed to more women having cesarean sections, more scars, more adhesions, and we were worried that it was going to increase more. With the last report, it decreased a little bit, but it is still a significant cause of maternal mortality. And this represents 30% of all the women who actually have died. So when they looked, thank you, at the reason for these deaths, one of them was a lack of skilled doctors and nursing staff, and obviously our referral pathways and the travel, the distances and stuff. One of the things that struck me was that only 32% of women who died due to bleeding after cesarean section had a hysterectomy, and all should have had hysterectomies. Similarly, 56% of anesthetic-related deaths were due to failure to protect the airways, and all these deaths occurred at district hospitals. So what that's telling me is that, similar to what Bruce had mentioned earlier, we have a lot of medical officers put in positions in district hospitals where they are taught to do spinals possibly, but are not comfortable doing general anesthetics if they need to convert. Similarly, that 32% of women who did not have hysterectomies probably were not with doctors who were able to perform a hysterectomy. And then to speak about the cesarean section delivery rate, how we interpret it. So in general, in South Africa, the cesarean section delivery rate is about 25%. I think that's quite a fair percentage. In the Western Cape, we in the Metro West, our cesarean section delivery rate is 30%. In state institutions, it's a vast difference to our private institutions where it's about 70%. But you need to remember that you often have cesarean section on demand in private. There's a lot of variation between different provinces, particularly Limpopo and Mpumalanga, where the cesarean section delivery rate is 18%. Now, if you remember when I spoke earlier about Uganda and Kenya, their cesarean section rate was 0.1 to 1%. And that shows such a vast difference, because you want your cesarean section rate not to be high, but you want it to be a value that determines that you are able to provide a surgical service when needed. If your rate is too low, that's where you run into problems. And that is what we have in certain parts of Africa. Thank you. So what they recommended to improve things is, if you take a look at the conventional model, and this is what we have in Cape Town at the moment, in certain parts of South Africa, is that women book at midwife obstetric units or MOUs, and they are then determined whether they're low risk or high risk. But sometimes a woman who is low risk can become a high risk patient during labor, and then she has to wait for that emergency medical service transport to get to the appropriate hospital. So what we've realized is that if we had changed our model to what we call an on-site midwife birth unit, where a regional hospital where all women attend one hospital, but you have that on-site unit at there where the low-risk patients go to, then you are eliminating that problem of transfer. This system was adopted by the National Department of Health in 2016, and it's been approved by the World Health Organization, and it is the model that is used in most developed countries currently. In South Africa, I'm aware of 2 hospitals that are using it. We have Freer in East London, as well as Dore and Ginza in Port Elizabeth. Thank you. Next. So what needs to be done for obstetrics in limited resource areas? I think skills, definitely we need to educate our doctors, especially in district hospitals, about the use of appropriate uterotonics, cyclocapron, and conservative surgical techniques such as B-lens sutures. But also something that we are not doing, and I don't think it's been really discussed, is that we should not only be training our doctors for cesarean sections, but possibly for subtotal hysterectomies. And that would be the last thing you would expect from me, because I'm very much about getting that cervix out and preventing cervical cancer. But I've had a change of heart, because when looking at the number of women dying because they're not getting appropriate care, that is something that I'm considering, because teaching someone to do a subtotal hysterectomy, which is less difficult than a complete hysterectomy, may actually be life-saving. The alternative is the systems change, as mentioned before, where the woman is on site and able to access appropriate care. And of course, we need to do a continuous audit and audit loop. Thank you. So I just wanted to show this one slide, because when I spoke about the cesarean section rate, obviously, if you're not able to provide cesarean sections when needed, you're going to have obstructed labor, and you can have a lot of complications such as obstetric fistula. And we don't see a lot of this in South Africa, certain parts, but not often. But in parts of sub-Saharan Africa, particularly where you have a low obstetric rate, you have quite a lot of poor outcomes for the women and possibly potentially for the babies as well. If you look at some of these pictures, these women are young. They are often ostracized or stigmatized and unable to live in their villages because they may have smell. So they often stay in little obstetric fistula villages. So FIGO has initiated some training on how to repair fistulas, and one of our trainees or registrars who trained with us is one of these doctors from Malawi who goes out and performs or tries to do fistula repair. But what is really alarming is that she told me that only 1 in 50 women are able to access fistula repair. The good news is that if they are offered it, they have an 84% success rate. Thank you. So you can press that again. So just to give you a background, that there are about globally 213,000 pregnancies. Thanks. Of these, 40% are unintended. Thank you. Of which 50% end up in abortion, and 48% of these abortions are unsafe. So some of the questions I have for the ASAS trial, for example, when they say that the majority of them benign, how many of them are early pregnancy complications, such as potentially unsafe abortions, which may result in acute surgical emergencies with bowel injuries, etc. Contraception cannot be overemphasized when it comes to women, because I suspect that a lot of these complications may be due to unintended pregnancies. Thank you. Just to briefly talk about oncology, we know that in South Africa itself, there's inequity with regards to cancer. Most of the specialist centers are concentrated in the Western Cape and Gauteng. The government has recognized in this document that there are unacceptable waiting times. There's a lack of functional radiation equipment and lack of cancer registers. In South Africa, we have 2 cancer registers. One is a population-based registrar, and one is a histology-based. So the histology-based is a little bit difficult because that means you're only documenting cancer patients who attend the hospital and not necessarily those who are at home and missed. And we really need to combine these registers because they're such a vital source of data. We also have limited cancer mortality data. Thank you. We all know, or if you don't, that the top 5 cancers in women, breast has superseded cervix. Cervix used to be number 1, and breast is superseded in South Africa and definitely globally as well, followed by cervix, colorectal, uterine cancers, and lung. I was quite surprised when doing this talk because I found the GlobalCan 2018 figures and found that vulva has now become one of the top 5 in 2018. I'm not surprised though, because HPV disease has been increasing, and what we are seeing anecdotally, and I'm sure it's reflected in this as well, is that we have younger women who are having HPV-associated vulval cancer, and we're seeing a significant increase in that. So I will have to watch that space. Thank you. Before I can speak about surgery in Africa, I do need to explain what's happening in Africa with regards to the radiation machine capacity. So in Africa, there are approximately 3 million cancer patients per treatment for 1.2 billion people in Africa. And compared to what we should be having, 400 to 500 per treatment unit. Radiation machines are concentrated in certain countries, particularly in South Africa. We have 92 radiation machines, and North Africa has a lot of the others. Together, they contribute to 60% of all radiation machines in Africa. One of the significant points to note is that when you are giving radiation, there's external beam where you radiate to the abdomen in terms of gynae, and what is very important is teletherapy, which is what we need for cervical cancer. So there is fewer than 1 teletherapy machine per million people, when 4 to 8 is the recommended ratio. So often it is not only the machine that is not available in Africa, but rather what I find quite interesting, it is the legislation regarding radioactive isotopes that they won't be allowed into countries because the brachytherapy or teletherapy requires a radioactive isotope. Thank you. So with regards to breast cancer, which is the commonest cancer in women, as mentioned before, the survival in the USA is good with a 92%, and this is because the majority of cancers are detected early because of the media screening policies and mammography that's available, it's a very different picture painted in sub-Saharan Africa, where women present predominantly with stage 3 and 4 disease, and where surgery is not actually what they need, but rather palliative chemotherapy. There are also delays in seeking help, and this is multifactorial, from parts about no screening available to points about access to care, as well as certain cultural beliefs. So many women would first see other doctors see cultural helpers prior to seeing a doctor. Thank you. And I just want you to take a look at this graph. It's not very clear, but these are countries in Africa. And if you take a look at South Africa, which reflects the, if you look at the patients treated surgically for breast cancer, and I just want to know that this is a private center, but 91% in a private center in South Africa receive surgery for breast cancer, as compared to areas of Nigeria that only 35% of women are treated. And what is important to note here is it's also got to do with the fact that in certain countries such as Nigeria, there's out-of-pocket expenditure in that there's no state payment for things, so every woman has to pay for every blood, every investigation. So sometimes they may have the facilities but cannot afford the facilities. Thank you. When you look at cervical cancer, which is the second commonest, 80% of deaths due to cervical cancer occur in developing countries such as sub-Saharan Africa. Of note, it's got a higher case fatality ratio than breast cancer in both South Africa and Africa, and the least media attention. And why I say that, I often refer to cervical cancer as a shy cancer. It's the cancer that doesn't get spoken about. Women are not encouraged or are shy to speak about discharges. Have you ever heard anything on the radio about HPV vaccination or screening? Very seldom, but you will hear a lot more. You'll hear about the pink drive. You'll hear about Flamingo, which is important, but there is actually no NGO for any gynecological cancer in South Africa currently. Thank you. Next. So I just wanted to give you an idea so that you could understand about what this does not represent the whole Western Cape, but just the number of cervical cancer cases that we see at Groote Schuur. If you take a look at the 2018 block, you'll see stage 1, there are about stage 1 and 2, there are 46 and 49 patients. We can only offer surgery to all stage 1s and up to stage 2As. So the majority of women do require radiation therapy at Groote Schuur as well. And the surgery varies from cone biopsy to a simple hysterectomy up to a radical hysterectomy, which requires more skill. We do about 25 radical hysterectomies per year, remembering that there are other surgeries happening at Tygerberg as well. Thank you. So in terms of surgery for cervical cancer, it is curative for the appropriate stages, but you need to have skilled surgeons who are able to know what surgery is required. What we do see happening sometimes is inappropriate surgery, often when no other cancer care option exists. So we may have a lot of patients coming from other parts of Africa who have had simple hysterectomies inappropriately, and then because there are no other radiation machines, and it's a very difficult scenario to broach, because on the one hand you have that surgeon there who's trying to do the best, but there's nothing else. But often inappropriate surgery doesn't really help because they recur and often have lots of complications. As mentioned by Bruce, we need to improve the quality of care, especially in the post-operative period. And surgery really is not only about the procedure, but the pre and post-op care. And we need to do ethical practices and empower our surgeons rather than bringing in people from overseas just to do surgical marathons, etc. Next. I also want to highlight that other cancers are on the increase, specifically for women. As mentioned before, HPV-associated cancers are not only limited to the cervix. There's also going to be a major increase in ovarian cancer, predicted to increase by 55% by 2035. Thank you. And this study that I was involved with really looked at the World Ovarian Cancer Coalition, identifying challenges and opportunities to improve survival and quality of life. And the reason I mention this is because ovarian cancer is treated surgically for diagnosis, symptom relief, as well as staging. And we only see about 30 to 40 cases currently at Groote Schuur, but the numbers are going to increase. So surgery is going to become quite a significant part. And we're looking at bringing the study to low-resourced countries. Thank you. So in essence, what I do want to say is that with regards to women and surgery, pregnancy and cancer is a significant burden in Africa, as well as surgery required later for obstetric complications. Quality of care needs some thought. There are other unknowns. What about surgery for trauma or gender-based violence or simple surgical procedures? What are they for? Are they for, from the ASAS trial, were they related to early pregnancy surgeries? Were they related to appendicitis? It would be quite interesting to know what happens in women. And in South Africa and Africa, really, we need to develop realistic national surgical plans with imaginative solutions, but we can't do this without political will, as mentioned earlier. A competent workforce is required, so we do need to train our doctors, but we need to do this in a way that is sustainable, that they stay and they continue and train others. And we need the infrastructure support for surgery. So my invitation really is an invitation for change. The role of surgery with regards to women needs more definition and not just limited to maternal health. We need to encourage more research, discussion, and of course advocacy, and of course more questions. Thank you very much.
Thank you so much, Dr. Adams. Yeah, I think the way you ended that presentation just really encourages us that there is more that needs to be done. I'm just going to move into a quick Q&A session. We've had quite a lot of questions about the same idea, and it's for you, Prof Biccard. It's that there are these huge disparities between African countries within Africa. So you mentioned Botswana, South Africa having much higher rates of surgeries compared to other countries. What are the causes of these? You mentioned that some of them are political. Are there any success stories? Are there any ways that we can analyze the political differences between these countries? And how do we advocate for increased access to surgical care if it is a political issue?
Sure. Such a difficult question. I think the first issue is that there's a lot of structural barriers in that the resources are really limited. So, and then the second thing I think, which is so we've got an environment with limited resources and limited surgical facilities. And then on top of that, Africa being with very poor infrastructure, so getting patients to surgery is really difficult. So I don't think it's. I know I said we need. There's a political barrier that we need to move through. The reality is there's little money for anything, but we do need to make sure that the importance of surgery is understood, and I think that's the most important thing. I do think we can make a big difference by focusing on simple systems quality initiatives as opposed to looking for small innovative solutions. So I'm convinced that the approach, for example, with cesarean sections, for example, would be to focus on identifying the woman at risk of hemorrhage, putting in place systems which allow you to do checklists for hemorrhage, to make sure that there's adequate surveillance. These are very simple things, and I think that sort of philosophy will go very far in improving surgical outcomes. But our biggest problem is going to be improving access, and access is going to require a lot of money. It's going to require civil and engineering and a whole lot of other things which are far broader than just surgical facilities and surgical personnel.
Yeah, thank you for that. I think the fact that the ASAS study was done such low resources and still manages to produce such excellent data is, in a sense, an indication that this sort of thing is possible with low resources. And then I have one question for you, Dr. Adams. It's asking, are there any studies or information that we have looking at the pathway of accessing oncology and surgical oncology care in South Africa, and how do we do that better?
Quite a few studies. There's studies looking at access or delays in access and reasons for access with cervical cancer as well as breast cancer. And I think one of my fellows did one qualitative and quantitative study, and it's quite, there are lots of problems, even in South Africa, which is like Cape Town, where you think you would have access faster. Patients wait 3 to 4 months before getting actually referral to cervical cancer. So there is quite a lot of research happening, more so over the last few years, looking at access.
Thank you both so much. I'm going to hand over to Prof Mswime to link, conclude, and then send us off. Thank you, Prof.
All right, thank you so much to both of you. I mean, these were excellent talks, and I think very eye-opening more than anything, because so often, especially as clinicians, as surgeons, we think about, what we're doing in the context of the hospital, in the context of our department, and not realizing, how many patients actually die after surgery, not realizing how many patients don't have access to surgery. And so this was very eye-opening for me. I mean, I am quite aware of some of this, but I think, especially the intro that Bruce gave and leading to Tracey's talk, I mean, you highlighted and touched on so many important things. And I think, one thing that's really important is just the need for more surgeons, and, access to surgery can only happen with an increase in the number of surgeons and healthcare workers that are available to provide surgery. So on one hand, I think, this is really to encourage medical students and people who haven't quite chosen what specialty they want to get into, to start thinking about surgical specialties. And I particularly want to highlight the role of women in surgery and the fact that we need so many more women, because, previously, at least when I was training, we were discouraged as women and told not to go into surgical disciplines, but we realize now how important it is to have more females in surgery, more women in surgery. And so I just wanted to make that important note, and just to say, understanding these things, these concepts, changes the kind of surgeon that we are training, that we're developing, because we're developing a surgeon who understands that they work in a health system, they work in a bigger world where they have to understand what the outcomes and what the bigger picture is at the end of the day. And then you also spoke about things like inappropriate surgery, and it's not just about cutting and counting numbers, but it's also the quality of care and making sure that what we do is important. And this will tie up very well with what we'll be talking about next week, the barriers in access to surgical care. On our next talk, we're going to have Prof. Steve Reed and Dr. Tracey Adams talking to us more from a primary healthcare perspective and a public health perspective. But before we go off, we're really excited and honored that we've got the Dean of Health Sciences on board, and he did have a comment that he wanted to make. So I'd just like to give an opportunity to the Dean to say a few words before handing over to Savannah to close off this session.
So thanks very much for the invitation to comment. I'm not sure that I said I had a complete comment to make, but I did want to say thank you to the students for convening an exceptional discussion. I think that both talks begin to remind me of a couple of things, and I'm trying to think about what is their relevance for a student surgical society, or perhaps what is their relevance for graduating health professionals. So that will be my reflection for this evening. And the one is Tracey's picture about the ward with the fistula, patients with fistulas in it. And it reminded me of the book, and I'm not sure how many students have read the book by Abraham Verghese, Cutting for Stone. Now, in Cutting for Stone, a pair of twins are born in dubious circumstances, but the one goes on to be a doctor in a hepatology liver transplant unit, and the other teaches himself medicine in Ethiopia and manages this terrible smell that emanates from the ward of the patients with fistula. And part of that discussion in the book, you come to realize just how we learn things is completely different, and the impacts that we can have are often the same. And so perhaps the challenge to students, and I know that our system doesn't always allow that to happen for you, is that you'll often find yourself in a health system where knowing a lot of things is highly valued. I want to argue that what these two talks demonstrate for us today is to know how things relate to each other is far more important. So how you process the knowledge that you accumulate over this time is probably as important as all the facts that you will accumulate. Because in many ways, what these talks again demonstrate for me is what I'm continually calling a decolonizing idea. And for me, decolonization in this context of surgery is really about shifting the conversation from cure to prevention. So in the burden of cancer surgery, yes, there's a burden which exists now, but your generation's practice must be geared towards preventing the significant burden that we have. So in many situations, the burdens that we have in surgery, pregnancy is a particular one because it's a little bit different to all of the others. But it's really about changing the way we think in medicine particularly, but in the health sciences in general. How do you prevent? And here, I liked Tracey's closing remark, where she spoke about the idea of research, discussion, and advocacy. Because maybe that's the skill that students need to leave with. That when you're engaging in research, to ask the right questions. That when you're engaging in the discussion, to talk to the right people. And sometimes they're above you in status, and sometimes they're below you in status. And this really important issue of advocacy. You know, the pathologist I think it must have been the 1400s, Virchow, spoke about the fact that doctors are the natural advocates of the poor. And I think this whole space of centralizing surgery as a public health discipline is about us challenging the right traditions. Because the way we think about things is often in a particular paradigm. But I really just want to thank the two speakers. I thought the talks this evening were really, really important conversations. It is this thing about the right discussion that we're having. And I think what I hope it does for students is begins to help them to think differently about the many problems that they will encounter in their learning. And perhaps the different people you will encounter in your learning as well. But thank you very much. Thanks for the event. I'm not sure if I can get to another one later on, but thank you very much.
We would love to have you at the next few ones, Prof. And the previous ones are also available on YouTube for you to catch up if you missed anything. Sav, do you want to close us off, please?
Sure. Thank you so much, Prof, for those very, very interesting points. And I think that you've definitely given us as medics to really reflect on and think about going forward after the series even ends, about our role as medical students in, surgery and as potential surgeons one day. So just to close us off, on behalf of the UCT Surgical Society, I just wanted to say thank you to our wonderful speakers for joining us this evening. Firstly, thank you so much to Prof Mswime for introducing and closing off the discussion so beautifully, and then to Prof Biccard and Dr Tracey Adams for outlining the burden of surgical disease in Africa so succinctly for us. I think for me personally, what really stood out was that the surgical need in Africa is absolutely alarming. And I think that if we wish to achieve universal health coverage in Africa, improving access to quality surgical and obstetrical care is essential in that process. And so thank you to our speakers for the engaging and insightful talk. Then just a couple of announcements from our side. As has already been mentioned, if you missed the previous Global Surgery webinar series, you're welcome to go to our YouTube channel. It has been uploaded there. Then this talk will also be uploaded on our YouTube channel. So if any of your friends missed it, or if you enjoyed it so much you'd like to watch it again, then head over to the UCT Search Doc YouTube channel. You'll find them there. Lastly, the next talk in our series will be happening the week of the 20th of July. And as Prof Musweme mentioned, we'll have Dr. Tracey Adams and Prof Steve Roos speaking to us on barriers in accessing surgical care. So please keep checking our social media pages, Instagram and Facebook, for any updates. Then I just wanted to say thank you to all of our local and international guests for joining us this evening. We really hope that you enjoyed it, and we look forward to hopefully hosting you at the next webinar series. So enjoy the rest of your evening, and you may now leave the meeting.